Hi.
Hey,
We'll see if Jenna shows up.
okay. Well, I compiled all of her history. I just don't have the images.
I also did that
Oh,
and how to use the imaging system. So we'll be okay.
okay. So you have like the images then? Sweet.
I actually have access to just let me make sure I'm signed in to it right now. Um, yeah, I'm actually have access to the viewer. Um, so I'll be able to share that when ready. If needed. Now she hasn't texted me to say like, sorry, I'm not gonna make it, but Jenna made it.
Yay.
I have a case that's literally being induced like any second. So I'm gonna do my I have my phone, so I will likely have to
Jet.
leave, but
Yeah.
I'll do my very best. Um, Jess, can you pull up the fluoro? I still cannot get
Can't
Fuji.
get it. Yep, I already have it up and ready to go.
Thank you.
So once we get rolling, I can uh share that over here.
That'd be awesome. Thank you so much.
Absolutely. You just have to tell me what I have to do.
Okay. And you have the scope images
I
too?
do. Well, I have the yeah, scrolling through it.
Yeah. Okay. Great.
And just I have all the slides pulled up.
Perfect. I also have it. I was ready to go.
We were on it.
I
On
appreciate
it.
you guys so much.
Clearly, we both have anxiety.
I
It's fine.
Anxiety is an understatement. Oh, all right. Well, let's see. It's 12. People are still logging on, but Jenna, since I know you need to go, I don't know if you want to get started just real quick since people are logging on. Welcome to Nephropath, Uropath Rounds. I am not Rachel Cianciolo. And Sarah Lynn is also not Rachel Cianciolo. She is in
That's
Hungary
correct.
right now, and is going to start lecturing, teaching tonight, I think. She said that her flight was very delayed and she got there without her luggage. So her luggage did not make it on the plane and she has to start lecturing today. So she's really excited about that. Um, we have a very interesting case that Dr. Ati is going to initially present, and then Dr. Lynn is going to take over. And so, Jenna, do you want to give a little intro and then I can pull these images over?
And you guys will have to update me with what you talk about.
We
Sorry.
will.
Okay. Um, so I saw a 6-year-old female spayed cat, not a fancy cat, just a normal cat, with a chief complaint of urinary incontinence. I don't have a PowerPoint, so you're just going to have to listen to my voice. I apologize. And so her history was that for the first 3 years of her life, when she was owned by this set of owners, she was normal. And I think that that seems like these are very astute people and seemed like truly was normal for the first 3 years. Develop what sounds like a UTI from everything that we can tell in the records that corroborates with the owner's history, had recurrence of UTIs, and then in that same period of time, after the onset of her first UTI, developed urinary incontinence. And when I describe incontinence, I mean she is dripping incontinent constantly. So you examine the cat and it is drip, drip, drip. On every exam, at every record, she's had a small bladder, and eventually got referred to a surgeon for this problem who did a CT, and the CT was read out by a radiologist saying that she, quote, had bilateral ectopic ureters, and then was referred to me to deal with that problem. And so on exam, when I looked at this cat, she did have a small bladder. She otherwise looked very healthy, and had some perivulvar dermatitis. I spoke with the owners and asked that, I said, this is really weird. I looked at the CT myself. I wasn't convinced she had ectopic ureters on her CT, and said that I think that's really CT can be really misleading. And so I recommended that we scope her as a starting point just to kind of see what's going on. The other abnormality that was seen on CT was that she does have a urethral remnant. And so the thought was that her current UTIs may be related to that. But I went ahead and started with a scope. And Dr. Hokamp is my lovely colleague who's going to help me because we just had an update of our system and my computer will not allow me to pull up our PAC system. So will you scroll through a couple so we see that proliferative tissue? So this was her urethra, and then it ends up kind of ending when I can no longer find a lumen right in this region. That was the vagina. Yeah, so go back. Yeah, right there. So her urethra ends with this
It's
proliferative tissue. And I tried to find a lumen. I tried passing a wire and was unable to pass a wire. And this tissue, I mean, you could almost get the impression of kind of like banding across it, and it doesn't have like smooth mucosa that just ends like a typical stricture, at least that I've appreciated. So I tried to pass a wire so that I could get a contrast study and see her get to her bladder. And my wire was doing really weird things. And so I ended up just injecting contrast to just get a better sense of her anatomy. And then if you will pull that third image study, yeah, that one is great, Hokamp. So I am at this obstruction and I inject contrast. And you can see I get beautiful pilograms and a pacification of her ureters and bilateral pelvises before I get a lot of contrast in the bladder.
That's
And
good.
so at this point, I was suspicious that we had a stricture kind of right where her ureters come in at her bladder neck. And there was more resistance to flow going into the bladder than to her ureters. And so my presumption is that she has this stricture, and I use the word stricture in the sense that she has a narrowing of a tube and not so much as sometimes what's described as stricture as this fibrosis. And it seems like depending on what body of literature you read, there are differing definitions. I don't know what the proliferative tissue is. I biopsied it, which is why we're here. But that is what I ran into. And so I then backed the scope up and did another contrast study to get a better sense of her urethra.
I think
And
was that, I think it
that's
was,
the 106, one more over.
106.
Yeah, that one.
I think
It'll let you. And so here I backed the scope up. I was injecting contrast through the scope, and you can see she gets like this beautiful opacification of both of her ureters. You can see her UVJs really nicely. And then, that contrast went up to both pelvises. I was much more careful the second round. I didn't expect for contrast to go up her ureters the first time, so I kind of injected contrast fairly rapidly, and I distended her pelvises bilaterally, which was not intentional, and so I was a little bit more cautious the second time around. And I think she's incontinent because she just drips. The only thankfully she just drips and her urine leaves the cat's body. And otherwise she would be bilaterally obstructed. So that's where we're at. And then I got some cystoscopic biopsies, and I apologized to the IVRPS group at that time for the crappiness and the quality of the biopsies. I call them my 6-cell biopsies because they go through a very small scope. But that's where we're at.
and Jenna, since you are going to have to run off possibly quickly here, are there any updates right now on what the plan is next? I know you've
Yeah.
already gotten a prelim from Rachel.
Yeah, so my plan is I am going to take her to I could never get a wire into her bladder. Every single time it went up a ureter. um, every single time. It was really annoying. And so I gave up, and I just said, okay, I talked with the owners, and the plan is to take her for a antegrade approach, and probably just do it open and do a partial cystectomy to get rid of her urachal remnant simultaneously, and then pass a wire from bladder to urethra and balloon her. And I am debating if I use a chemo-eluting balloon or just a plain balloon as far as restricture formation. I understand that this disease is still active, it looks like, and I haven't gotten all of the histopath results.
Mhm.
So a little bit TBD as far as what my final management strategy will be, but my plan is for sure to balloon her and give her patency, hopefully, between her bladder and urethra.
Cool. I will stop sharing and let's see, wait. Da, 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 da. Actually, Sarah, you might be able to just share.
You might have to stop share. It says host isn't allowing multiple presenter sharing for this meeting.
Okay, try again.
Okay. So we have a couple cases to kind of bring up in comparison for this. This is the tissue that we received for Tiger Lily. The bulk of it is, sorry, pause for it to actually get clear. The bulk of this is actually urothelium, if you want to believe me. Let's see. Let's try if I refresh. Oh no, access denied. This is what I get.
Do you need me to pull it up? I have everything ready for you. Wow. Maybe. Maybe.
Okay. I think it's just because I was on this for too long. I tried to prepare too far in advance. That's what was happening. So hopefully you guys can see that. So majority of this are kind of little islands and papillary projections of urothelium. Occasionally you can see some fibrin and some hemorrhage along the surface. The majority of the sample is that mucosal aspect, and this is pretty much the only portion where we have either stroma or underlying lamina propria. So when it comes to evaluating urothelial lesions, as you probably have heard, we want to look for invasion into the deeper tissues to kind of suss out if there's evidence of malignancy. This is a little bit hard to do on this case, mostly just because there's not as much stroma there, but we do also look at other histologic and individual cell features. There's not a lot of anisocytosis, which is what, if somebody wants to say in the chat, maybe a non-pathologist.
Anisocytosis. No one wants to answer.
Okay.
Right?
So not a lot of variation in cell size, and there's not a lot of anisokaryosis, which is variation in nuclear size. Not seeing, there's a mitotic figure here, but overall, this doesn't look like it's super mitotically active. We do have some inflammatory cells, which are kind of down here in the underlying stroma. And it's a few neutrophils and potentially some macrophages, but it's kind of hard to tell. Sometimes when we're looking at these deeper lesions, we kind of get worried about these little what look like islands that are invasive. But when you have a section that's going in and out of plane of section, it's very possible that this is just a mucosa that's kind of dived down into that. So and then you have a couple eosinophils there as well. So overall, it's kind of difficult to say what's going on with this. We talked about it in our group, and our major concerns was like, is this some sort of like polypoid lesion or polyp, or is it a really well differentiated urothelial carcinoma? I think what makes this difficult is the fact that this has a 3-year long history. So if it was a urothelial carcinoma, you would expect it to have some degree of progression. So we're kind of leaning on the more benign proliferation, but ideally, if you want a more definitive diagnosis, I think you're going to want a biopsy from that, rebiopsy from that. So that's kind of what we have on the histopath side.
And
We also did
gram stain, is that correct?
yeah. So we did a gram. And this is our gram stain, and basically we just try and look around for any evidence of bacteria along the surface, or deeper in the tissues. From what I could see, I wasn't seeing any bacteria in this. But you can see that it gets a little bit more difficult. It looks like it's kind of going in and out of the plane of section, so we're losing a little bit of the tissue too. But I don't get the vibe that there's bacteria in this. But if you're really wanting, I mean, obviously you guys did culture, so that's going to be more definitive. I think most of this does look like urothelial in origin. I'm not seeing a lot of necessarily like fibrosis, what Jenna was talking about earlier with a fibrotic stricture. So this is kind of weird.
And Jenna, y'all did culture, correct, on this one, and it looks like it cultured.
Yeah, she cultured positive for Enterococcus faecium.
Okay.
So,
And
that was urine, that wasn't a tissue culture?
Correct.
Okay.
It was really challenging to biopsy her.
Yeah.
So I prioritized tissue for histopath.
Thank you.
Since we got urine, recognizing they may not be the same, but it was quite challenging to get decent tissue from that spot. So that's what we did. It's possible when we take her to surgery, I might be able to get better biopsies. But yeah, I sent it all the tissue I could get. There was lots of biopsies where I got like almost nothing, or it was just like crushed crap. And so I didn't even put those in for you guys. So it was just really hard to get like decent biopsies. I mean, the scope is a teeny tiny scope. So there's just we use what's called a backloading or a bigopsy device, but that takes up literally like everything you can see through the scope. It like takes up the
Yeah.
entire camera. Not your camera, but the scope lens itself. And so it just, and it's a small space. And her bladder even like was getting full, and I didn't have a way of like expressing it. I had to do a decompressive cysto because I couldn't get volume that I'd gotten into the bladder out. And so there's just a lot of technical aspects to this case that made getting good biopsies challenging.
I'm gonna ask forgive this if this is a dumb question, but would fish be warranted in this case?
Yeah, I think so. I don't think it's a dumb question. In the proliferative urethritis cases in dogs, that this
Yeah, I was
actually had
reading
some
that
resemblance
commonly.
to. The majority of those patients were fish positive.
Hmm.
So I do think if you think that the tissue is good enough to send for fish, maybe we
Yeah.
do so.
Hmm.
So we have been doing fish actually here through the GI lab. We do it sort of on a limited, they don't advertise it, you know, commercially, whatever. But if we've got individual or one-off cases, we can submit it downstairs. And so usually we just check with the clinician, but I guess, Sarah, that's a question for you if
Yeah, I mean, I think this is reasonable. There's plenty of tissue. It's all superficial.
Yeah.
So if there's any bacteria that's like heading down further into the stroma, we're not gonna be able to catch that. But if it's embedded within the urothelium, that should be more than fine.
um we can get you across, Jenna, or if you want to see how the next biopsy goes, if an additional biopsy is taken when you go in next time, we could look at that.
Um, so because of this, your gross description or your description from cystoscopy of proliferative urethritis, we have another case to kind of compare that to, but I want to pause to see if any of the clinicians have any input for while Jenna is here.
Yeah, if anyone has any better ideas than me, please do chime in.
I deny having better ideas than you do, but just sort of um, looking at the images, starting with when you put contrast in the anterior end of the passageway you could get to up the urethra. It, I'm guessing that your biopsy access to what you could then do from that position was really of the wadded up bottom end of whatever process had caused narrowing slash obstruction slash restriction of urine flow uh, between the area that you describe as bladder lumen and a lower portion of the bladder into which the ureters are still inserted. So I'm not quite sure that it's urethral as opposed to bladder neck region as opposed to urethral. And that the real problem, with that issue, there's contrast sort of diffusely in the lumen, if you will. And then there's the sort of like a little marble of contrast right at 11 o'clock from the cystoscope. But there's sort of a little passageway between those two. So right above that and at 11 o'clock. And that area probably with soft tissues on either side of it is the location, if you will, of the main process. And I doubt you'll get to understanding of it until you go in through the bladder and look at the bladder from the bladder's point of view rather than expecting. But that it looks to me like it's near the trigone, but just past it up into the bladder.
Yeah,
So
I agree with
anyhow,
that. I agree with that. Originally, I wasn't sure. Like, I looked at when I was scoping, effectively from a retrograde perspective, I thought I was in urethra, and then just it dead ended, and then and that tissue reminded me of proliferative urethritis. But once I kind of determined anatomically where I was at, where things go from bladder neck to urethra, I think is really challenging in this case
Sure.
in particular. Um, just because that tissue, her normal anatomy is obscured by whatever this process is. But I completely agree. I think that this is the primary process is at the bladder neck. And there is that you can see like there's some small amount of contrast that gets into the lumen of the bladder before it diffuses into the greater body of the bladder. And there's almost what you can see is almost like a filling defect on the margins of that. There's like a narrower tube, and then this absence of contrast, and the borders are not a normal shape of a bladder. And so I suspect that that region is infiltrated with whatever this process is. And hopefully, coming from like you said, the bladder side, that's my plan is to go
Yeah.
from the blood, surgically open up the bladder and go into the bladder, hoping it's not neoplastic. I think it would be super weird for it to be neoplastic, and
Yeah.
and I don't know there's
So,
another clinician I spoke to who saw a case that was somewhat similar where it's strictured right at the same location. I don't know if anybody else has seen a similar case in a cat, because I think at this point now, knowing that there are two cats who've presented with incontinence, I am unaware of literature that has shown this. And so if anyone's aware of that or has seen cases, I would love to talk to you, because I think it is worth writing this up at this point, because I think if somebody were to put an occluder on this cat, for example, for avoiding disorder or storage disorder, not recognizing that her anatomy, I think that, they could cause bilateral ureteral obstruction. So I think it's important
yeah.
for people to understand that this can happen.
Um, Two questions. One, um, is there any history of an injury or surgery or anything back up, what
No, no,
between when the cat was urinating normally
no.
and uh,
She's
is the cat spayed?
she's spayed. That happened when she was a kitten.
Okay.
And then she's an indoor only cat. She has a person
Okay.
who is on the spectrum as her owner, and she's kind of like a support cat to the
Mm,
individual.
okay.
And so she is a such like she like practically lives on this person's lap
Yeah.
all the time.
It's now a pretty damp lap.
Yes, and like I mean, like when I walked into the exam room, when the cat was not in there, when I walked into the exam room to speak with the owners, there like it was notable the amount of cat pee that was on this woman's lap,
Yeah.
and
Sure.
blanket. So I think she is extremely well observed, because of
Um,
the lifestyle,
sure.
and so the possibility for trauma seems excessively unlikely.
So my second question is, after this procedure and the other parts of it and whatnot, did you and might be there be merit to going back to the CT and if you will, interpreting whatever the CT shows
I
in
think,
light of what you're
yeah,
not looking at ectopic ureters, but at this particular area. The other piece of this is that these views are all two-dimensional, and
yeah,
getting some sort of three-dimensional or spatial aspect of whether this material that's in the way is more dorsal or ventral or symmetrical or that kind of thing.
mhm,
I mean, something that is an outgrowth of the some problem with the uterine stump, for instance, or laying right over it or something would go up
I
on my list if all the problem seems to be coming down from the top as opposed to
yeah.
et cetera. So
I did go back to the CT retrospectively after doing this, and I honestly can't tell. The study is imperfect. Also, we it was only sent in, I wasn't able to do reconstructions, and it was only
Okay.
sent in, I believe it was dorsals. And so it made it really challenging. And the slice thickness is big enough to where as you go between slices, I think you're missing, like, it's not that big of a that big of an area. And so
Sure.
by having the slice thickness where it was, I was unable to ascertain a lot more from it. I think we might, if we can get the study uploaded into a different program, I might be able to
Okay.
get better recons in different
And
dimensions.
I've been away from all this for so long that the technologies of imaging are um,
It wasn't.
sort of my experience with imaging was medieval versus today. Okay, so but one would another possibility to think about is whether or not there is any potential merit to redoing or getting a new CT kind of a thing in to that would be more informative than and give you a chance to like um, focus in on what you now know is the area of abnormality and get a more of a three-dimensional or sliced, if you will,
Yeah.
view of it in different planes. But the surgeon will tell you a chance to cut is a chance to cure, and you get in there and figure it out from the bladder lumen down, and open it up if you can, and find out why, what it is if you can't, and go from there.
Well, thank you for your thoughts. Yeah. Hopefully I can report back in a month or so and let you know how it went.
Any other comments for Tiger Lily?
Not from the ClinPath side.
I think if, at least from histopath, like if we get another set from the bladder side, that might be more helpful. And if you're able to get a little bit deeper, we can see how infiltrative it actually is. But like I said, it looks so bland. And the fact that it's had such a long history, it just seems like it would be very unusual for a urothelial carcinoma, from my perspective.
The comparative case that we have,
Yeah.
if I don't know if you want to do that one.
Yeah.
It's Devin Schultz's case. He said he was not going to be able to be here, so we're gleaning what we've got from the history on
Mhm.
that one. Sarah, did you pull that?
I did.
Yay.
Okay. So this is Ember, and the 3 year Ember's a 3-year-old spayed female Texas healer. Had urethropscopy and cystoscopy because of stranguria, and they noted that it looked like proliferative urethritis on imaging. So they gave us bladder and then urethra and vestibule. And then later on, they had done cultures as well, and they were negative. We did gram on this as well, and it's negative. I can show it, but negative, so it's not that exciting. As far as the urinary bladder, looks a little bit different in that we've got urothelium seen here, and then that underlying stroma. And then here we've got that nice little like projection into the stroma that might freak you out. But it could just be a Brun's nest or just an artifact of cut, kind of what we're seeing here. But the urothelium, again, looks relatively bland. Not a lot of anesthetizitosis and esokaryosis. Every once in a while, you get a little bit of karyomegaly. But the underlying stroma, there's hemorrhage. You've got some occasional neutrophils, and then this is an eosinophil in here as well. Um, this is a section that's just looking at urothelium. The urothelium overall is thick. And here's a few more scattered eosinophils in here as well. And that's pretty much it for the urinary bladder. And then the urethra and vestibule, we got a lot of samples. And I'll first go in on this one because we can at least identify urothelium and stroma. So we again have more of that pretty abundant hemorrhage. We've got eosinophils and neutrophils, but the urothelium is thick, but it's not as thick as our other case. And then a lot of this tissue, it's actually really hard for us to even ID what it is. So degenerate neutrophils, nuclear debris, a couple eosinophils that are embedded within this, a lot of necrotic debris that's within this as well.
Sarah, a quick question. Those
Yeah.
areas with red blood cells, erythrocyte,
Yeah.
is that truly hemorrhage or are those congested vascular spaces, or at least some of them?
So both, you have both. So this is a vessel here. We've got capillary lumen or vessel lumen here, and then we've got it lined with endothelium. We've got a small artery arteriole, and then here, these are extravasated, so outside of the vessel.
Yeah. Okay. Thanks.
So you've got some degree of both. Good question. Let's see. But a lot of this is just necrotic. Like it's really hard for us to tell what cells they are. We can't ID urothelium in them. A lot of it just is random nuclear debris. And I'm trying to think if there's anything else on this slide. There's a lot of different spots to look at. There are some hair shafts in here. I think it's artifact. So I don't necessarily think that this is here's a hair shaft here. I don't think that this is actually a hair shaft in the urethra. And it could be from the instrument that was used. Or from insertion. So a lot of this is necrotic. And then, like I said, we did do a gram stain and didn't find any evidence of bacteria. We ended up calling this just a really severe neutrophilic and eosinophilic urethritis or vestibulitis because we can't really even make out what was vestibule versus urethra. And the bladder was just a mild multifocal eosinophilic cystitis. And there was at least urothelial hyperplasia that we saw. So a thickening of the urothelium overall. And so this kind of raised a lot of questions for me as a pathologist because we've started getting obviously more lower urinary tract submissions. And I really heard about this at the lower urinary tract symposium, but the disease proliferative urethritis. And I really had never heard about this disease in my like pathology training. And it's mostly from the context that proliferative urethritis sounds like a clinical name. Because when we're diagnosing an inflammatory process, we're usually looking for what type of inflammatory cell is there, except for in the case of like proliferative ileitis, when we talk about in horses and Lawsonia. But this kind of was, I started doing some digging related to this. And I wanted just to include a bunch of memes about the use of ethereal versus urethral. A lot of people confuse that on the internet, and I find it really funny. So I started doing some digging on papers and found two from JVIM that are a little bit more recent that talk about proliferative urethritis. And there's really not a lot in the pathology literature related to this. So I was wanting to do more digging, like where did this come from? And then these studies cited these studies where from 2004, there's a description of proliferative urethritis in 2 dogs. And then this study cited Moroff and et al., and they kind of talked about infiltrative urethral disease and then also pathologic basis of veterinary disease. I will say I did try to look for the 3rd edition online and I could not find it. The 7th edition doesn't talk about urethritis at all, which is the most recent one. And basically they just use the urethritis to describe hemorrhagic urethritis associated with urolithiasis. And then later on, when they go to describe inflammation, they just say urethritis is so rare, only cystitis is described. Fine. And so then I was trying to do more digging. And then in this case, they actually never call proliferative urethritis. They call it granulomatous chronic active urethritis. And so I'm interested in talking to the clinicians on where where the disease name comes from, just so I can get a better understanding of it. Because a lot of the lesions that you would submit for um, biopsy, they are going to be proliferative. That's usually the reason that you guys are sending it to us. And I couldn't necessarily glean from the cystoscopy from one of these papers on what would be the what would be the gross appearance of this to tell you that it's more likely proliferative urethritis versus some sort of neoplastic process.
There are people on this call who have more cystoscopy experience than I have, but I can start it off with a little bit of background. So when I was a resident, which wasn't like terribly long ago, a decade ago, it was at that time commonly when we saw lesions like this, and you can see in that image number 2, you can kind of get the impression that there is banding across a certain portion, of the urethra.
Mm-hmm.
And that's a pretty classic example where we see bands that go from wall to wall. And we, at least where I trained, it was commonly referred to descriptively as granulomatous urethritis. That name was called into question because histopathologically, this was not always consistent with a macrophage predominant inflammation. And so from a gross perspective, there has definitely been some people in our field from a clinician standpoint that recommended that we call it based upon its gross appearance, which is, quote, proliferative, and not put in the histopathologic description, which may actually be an inaccurate description based upon the cells that are there. And so at least when I was a resident, that move was kind of actively taking place, and my mentors had made a point of that. I don't know if other people have other history with that as far as, kind of when we made a move, but that was in my training. I do recall that was kind of pushed over the last, I would say, 10 years. And as you said, like eosinophils, we see in some of them, we see lymphoplasmacytic inflammation in some of them. And so Sykes's paper discussed, a lot of these were FISH positive with varying cellular infiltrates. So anyways, that to my knowledge, but there are probably people who know a lot more, but I can just speak to my own experiences. There was a push as far as using more gross terminology, unless you have a histologic cellular type.
As someone who's been around clinical veterinary medicine since the 70s and 1970s, not 18, and looked at the literature, shared the literature with my trainees and a variety of other things. I think that it's fair to say that there were times when clinical folks used nomenclature carelessly, and with maturing of our discipline and the move towards more evidence-based everything, trying to weed out the terms that are, and I'll just start with renal dysplasia for crying out loud. Ultrasonographers were making the diagnosis, if you will. And so diagnostic terms from long ago and 15, 20 years and back are probably promulgated by folks who weren't necessarily careful about the true meaning of the words going back to their, Latin and Greek roots, calling things inflammation that are not even inflammatory, or et cetera, et cetera. So calling it urethritis when it's all scar tissue might be an example. So, well, I think the movement to just to use a generic descriptor that has to do with shape and size and doesn't imply what you think you would see if you look through a microscope at it is probably a good idea unless and until somebody has told you what they saw through a microscope with it.
Yeah, somebody said as a pathologist, I hate calling this proliferative without epithelial proliferation. And yeah, I think that's what's really hard for me too is, and I would never bottom line it on a morphologic diagnosis as proliferative urethritis. I would probably have the inflammatory infiltrate as the inflammatory modifier, and then with epithelial hyperplasia. But you're going to see hyperplasia a lot secondary to a lot of different diseases in the lower urinary tract. And so that's where I like having it, the clinical name be almost like a morphologic diagnosis is where you ride the line in some misinterpretation, I think. And that I wanted to just get some clarity from you all on when you are calling this particular disease, or when you're suspicious of it. Just because on the histology side, even I think this is from Chuck Moore and describing it, it's very heterogeneous in what inflammatory cells can actually be there. And that might be a result of where we're at in the stage of infection, like thinking more neutrophilic is either chronic active or acute versus lymphoplasmacytic. We usually think about it being more long-standing chronic inflammation. But I was just curious. And then I like to make memes. So I made this and wanted to have consistent terminology to make sure that we're on the same page when it comes to the gross submission and from the pathology standpoint on kind of what that means for us moving forward.
I guess from my point of view, the renaming or the naming of it, I may be wrong, but in my mind, it was specifically triggered by the two case reports out of Ohio. The Hosteler, I think, is the first. And they christened it proliferative because of the sort of lack of macrophages and the other things. And I think people picked it up and ran with it from there on in. But I think it was more a rejection of the granulomatous term that had been used before, rather than an active, this is sort of thinking about the histological description. It was just that this isn't what we would classically consider to be granulomatous change, so we should call it something different.
Just as a quick update on this particular case, Ember, we got an email from Devin on May 8th that they started her on pred and marbofloxacin pending labs. She was clinically doing well at home. They did submit fish. They sent it through Cornell. He said he didn't realize that we can do it here. So yeah. And then urine and bladder wall tissue culture were both negative. But I don't have results of fish from him yet. And then Jenna asked if there was anybody else that had any other comments or thoughts on that. And if not,
I do have a comparative urethral lesion.
Go for it.
That I pulled up as well. This one was from April and it was from Friendship, and history with UTI, BRAF cadet did we say BRAF? Is that what? Is that what
Technically, it's BRAF,
okay.
RAF,
BRAF. Sorry.
whatever.
I have to change my lingo. Did not find any genetic variations associated with urothelial carcinoma, had hematuria, and basically found proliferative vascular tissue concerning for UC and the use of proliferative. That's why like it made me think of this. And so I'm curious on the clinical side of how do you guys delineate that? And so they submitted urethral biopsies. Oops, super zoomed in. Yeah, so there's a lot of hemorrhage, which happens sometimes, but looking at this sample compared to what we saw in the last two, there's a lot more variability. There's these islands that are actually invading deeper into the tissue. And in some cases, these little clusters of epithelial cells are actually within lymphatics. So this, and you can see an increased number of mitotic figures. There's still inflammation that's associated with it. Pretty classic for it. Any urethral lesion. And so this was urothelial carcinoma. I just wanted to show you guys that kind of comparison and how this is a bit more aggressive and invading into the tissues, but we also have that stroma that's kind of associated with it as well. Here, it looks a lot more proliferative and almost exophytic or moving outwards towards the lumen, but we do have those regions of invasion. And even in these like small fronds that don't have stroma associated with it, I would get concerned because of the increased mitotic activity. So those really prominent nucleoli and kind of large nuclei that are in here, that would already raise some flags for me that this would be urothelial carcinoma, even without the underlying tissue. But really for us to call it, we do need to have that evidence of invasion, which we do have in this case. So just wanted to have that as a comparison. If anyone had any comments or questions on that.
I was just gonna say, can you guys hear me okay?
Mm-hmm.
I'm sorry, my video, I have my cat is like on my shoulder, so
As it
she's
should be.
18.
This is perfect.
Yeah, just let it happen. But the nomenclature is an interesting topic because I was thinking about it, and when we say proliferative, at least for us as at Colorado, like the transitional cell carcinoma is so it's got those very on a cystoscopy it's kind of like coral. It looks like a coral reef, and so it's just so proliferative and so vascular looking. And so to me, when they say proliferative concerning for UC, that's kind of what I'm picturing. And then those other images for more of the older term granulomatous urethritis or proliferative urethritis is interesting because I suppose we typically don't use either term because we're more looking at what we think the etiology is and what the histo says. And so it's interesting because at least the ones that I was just trying to look up during rounds, their morph didn't mention anything about like that term. And so I think, they basically just in their morph do what you're saying, which is just describe the infiltrate, what they're seeing, and then the clinician can, they may say could consider fish, you could consider X, Y, or Z, but they don't say this could be consistent with the syndrome known as, like, I thought it was interesting. I pulled up several that, don't really say that, but
I think it
at
could
the same
be,
time, oh, go ahead.
sorry, I think it could be twofold. One, I asked some pathologists here about have they heard of the clinical syndrome proliferative urethritis, and they were like, no, I don't know what you're talking
got
about.
it. Okay.
And then
So
the other part, inside stuff or JAVMA, and that's not required for our boards necessarily.
Yeah.
And then the other half would be they probably don't want to commit because it is a clinical term that they're just going
Yeah.
to call what they see. And that's what we consider our morph. We're not going to, it's not best practice for us to morph a clinical name of a disease. We just call the findings that we see. If that makes sense.
Yeah. And so do you think from, you know, would your kind of thought be, again, just to, for your image of the two people kind of arm wrestling, do you feel that there needs to be a change in the terminology, or what do you think?
I feel like for me it's confusing because I want to know exactly what does that disease actually mean and what's the disease definition for
Mm,
proliferative urethritis if that's something that's going to get used. Um, or is this, you know what I mean? I just feel like it gets confusing, especially when there's varying levels of inflammation associated with it, and calling something an itis and not having an inflammatory modifier stresses me out a little bit. But that's me
yeah.
being a pathologist and being pedantic, but it's on
Well,
brand.
I don't think it's pedantic because I think it is helpful as a clinician to be like, there is not inflammation being seen, so I do think that's a fair comment. I think, I don't know, those terms are older terms. And so I wasn't, again, we tend to say inflammatory, we often will say infection associated inflammatory process of the urethra or inflammatory associated deep infection urethritis, or we'll say steroid responsive and we suspect an autoimmune. So we haven't really used those terms. But then I've often wondered if we're naming things incorrectly, but I don't know.
Hattie. Oh, you're muted. There you go.
Yeah, sorry. I mean, I actually thought it was interesting at the lower urinary tract symposium when there was a discussion on this sort of clinical syndrome, how convinced people were that you could recognize it clinically and say, oh, this is what it is. Whereas maybe I'm not as bold or confident in my sort of clinical diagnosis of it. So, I mean, I would definitely be thinking of it as a differential. And then if there's an absence of neoplasia, then I sort of back myself into that diagnosis. But was there maybe, and it was really interesting to hear about the sort of characteristic features and if it, if it attaches to both walls and things like that, that's much more likely that it's what it is. But I've only seen like a couple of cases or scoped a few myself, but certainly in those cases I was thinking TCC was a very real differential, and initial biopsies which were sort of small and cystoscopic, and then like so they couldn't find the tumor. Okay, I wanted to go in and take a bigger biopsy and convince myself that this isn't tumor before we do some heroic reconstructive surgery, and that was before the more recent publications. So yes, I think it is the clinical diagnosis, but I'm perhaps less confident that you can look at something and say that this is what it is.
I mean, even from the pathologist perspective, that's why we do histo and not just our gross necropsies too. So that's why I was curious. I'm like, oh, is there something specific that you guys can like, oh, this seems like it's more proliferative urethritis versus urothelial
I think that there are some gross lesions that definitely are more suggestive, and what Hattie was alluding to at the lower urinary tract symposium, and then depending on, I think also who you train with and who influences this nomenclature. I do think that there are some descriptors that make me more suspicious of one etiology over another. But I do think that we have to biopsy these animals. The other thing that I think that we should be aware of is, to my knowledge, the literature that you presented is all that there is. And I think the largest case series of this was 22 cases, if I'm not mistaken. And so, and within these 22 cases, if you looked at the histopathologic description, they were variable. And I questioned, even so, while reading these, can we actually call this the same disease, knowing that it has a differing histopathologic seeming etiology? Which I don't recall that being acknowledged in all of these. So I do think we need to be careful, and I do think that the word proliferative urethritis is used. I like the description of it as a syndrome. I think that there seems to be urethral disease that, when I use the word proliferative, is, I mean, there is abundant tissue from a gross perspective that tends to be obstructive in nature. I mean, syndromically, these cause obstructions in patients. And then, importantly, I think we have to distinguish that from neoplasia. But probably additionally importantly, we do need to understand the etiology, because currently some people feel very strongly that these patients should be immunosuppressed long term, which isn't necessarily benign. And so I do think a better understanding of this disease process is warranted. How do we go from here? I don't know if, I mean, like, is this, does this generate a letter to the editor of several journals, and we redefine this as, proliferative urethral obstructive syndrome with need for clarification from a histopathologic perspective? And I don't know, but I think your point is a good one, as far as we are using nomenclature that is potentially premature in our understanding.
Yeah, and I was thinking about, like, from a pathogenesis perspective of what actually is going on, and from somebody's comment of relating to pathology, when we call proliferative, we're thinking about epithelial, and it sounds like, from my understanding, that this disease isn't necessarily a urothelial proliferation. It's a band of connective tissue. And my thought from a pathogenesis is that there was urothelial ulceration, some degree of contact between the two tissues where an adhesion had formed. And there might still be inflammation that's related to that, rather than all of a sudden, it's not like you're going to get a random band of connective tissue that just decides to, I don't know, go on a journey across the urethral lumen. That's what I would think would be happening, but I don't know. Just based on your gross assessment saying, like, that it's a band of connective tissue that's across, because it doesn't necessarily, to me, scream an epithelial proliferation. It just sounds like it's connective tissue.
Point well taken.
Thanks for letting me talk about this and get in the nitty gritty about it. It's something that I feel like I never heard about and was so confused. And so then I tried to do deep diving, and then I was like, oh, so this is not in the path literature. It's just really from the clinical side.
All right, well, Sarah, it's your job to update all the texts.
Add it to my list.
Add it to your list to figure out and save the world. We're basically at 1:00. And Jenna, I'm so happy you were able to be here the whole time.
Yeah, I'm glad our anesthesia team's incredibly slow.
Okay. I'm glad you were here so that I didn't have to pretend to be you, because clearly I would not have been able to do that. And thank you all. I guess this is also just another plug that, yes, we are doing lower urinary tract biopsies. We can do fish here. We usually do it as a one-off basis, and so we don't advertise it on our website. Our website has updated recently through Texas A&M. So if you have any problems with anything, please email us, ivrps@tamu.edu, or just Google us. You should be able to find us, or email me directly, whatever. And
I'm sharing my last meme.
Okay.
I love them so much.
And with that, thank you, everyone. We hope you have a wonderful Tuesday.
Thank
Bye.
you.